Welcome everyone to today's segment of Health Mantra brought to you by Manipal Hospitals. I'm Heather and today we will be delving into the world of stroke management and treatment. Joining me today are two eminent professionals. I have Dr. Parul Dubey, a consultant neurologist, and Dr. Charudutt Sambhaji, an experienced endovascular surgeon and interventional radiologist, both from Manipal Hospitals, Goa. A warm welcome, doctors, both of you. Thank you so much for joining us here today.
Thank you.
Doctors, let's begin with a very fundamental question. What is stroke and how does it affect one's body?
Yeah, so stroke is a very common neurological condition which affects the brain. And the most common type of stroke that we deal with and which occurs is an ischemic stroke. Ischemic stroke means the blood supply or blood flow to the brain, to certain parts of the brain, stops.
Okay.
Due to which the function of that part of the brain cannot happen normally. So that is the most simple way in which we can describe a stroke, that a part of the brain stops functioning because of loss of blood supply to that part of the brain. This is about the strokes in which there is loss of blood supply. Of course, there is a smaller category of strokes which we call hemorrhagic or bleeding strokes. So, but we will kind of restrict ourselves to the discussion of ischemic strokes today,
Okay.
because they are the more common ones. Now, how does it affect? So, whichever part of the brain gets affected, the function of that part of the brain stops because of the loss of the blood supply to the brain at that time. So, suppose the right side of the brain gets affected in an area which takes care of the function of the left side of the body, like the facial muscles, the hand, the leg, then that side suffers from a paralysis. So very, very broadly, this is how a stroke will present, paralysis of one side of the body. But that is not just the only presentation. There are many other ways in which stroke can present, and it's very important that we all recognize the occurrence of a stroke. So the presentation of stroke can also be sometimes with just a speech change. Suddenly, a person who was able to speak normally now is speaking in a slurred way, or suddenly he is not able to understand whatever is going around. So his comprehension gets impaired. There may be a sudden facial deviation. There may be sudden loss of eyesight or loss of vision, or there may be sudden double vision. There may be sudden acute vertigo or giddiness and vomitings. So these are usual ways in which strokes present. There are many other ways in which the stroke can present, but this is the common way.
Doctor, you said that, it's a very common, stroke is a very common occurrence. How prevalent is it?
Stroke, the burden of stroke is very huge all over the world. And if we talk about India, the incidence, which means the new strokes happening every year, it is about 105 to 150 per 1 lakh people every year get affected with stroke. And if you talk about the prevalence, which means the overall burden of stroke that remains in the society, it is around 50 to 600 people per 1 lakh.
Wow.
Population.
Are we attributing this to any factors?
There are lots of factors which of course lead to the stroke burden. So we'll be talking about that in a while, I think. At that time we can discuss, but Dr. Charu would like to add something about this.
Yeah, so whenever you get a stroke, basically what happens is that the blood supply to the brain is cut off. That's what we call as an ischemic stroke. So ischemic and hemorrhagic strokes are two different strokes. So as spoken by Dr. Parul, so your brain is deprived of blood flow and you don't have oxygen and nutrients going to the brain. So brain is immediately stunned for a moment.
Okay.
And then over a period of somewhere between 6 to 18 hours, you get something called as evolution of the stroke. So stroke starts, the brain starts getting affected, and then over 6 hours to 18 hours, the brain's cells start dying. So this is called stroke evolution, which happens over 6 to 18 hours. and with an average time of around 8 to 10 hours is where the stroke establishes and the damage is done. And the presentation again can be facial deviation, or a slurred speech, or a weakness of one side of the body, or sometimes if the stroke happens in the back part of the brain, you may have a loss of balance, or some kind of other symptoms which are some feeling of rotation like vertigo, or these kind of symptoms. So these are not all the symptoms, it's not the only symptoms that you get, but there are some minor symptoms which clinicians could identify. But bystander or the family members should be able to identify at least these symptoms.
So you're talking facial deviation,
speech change,
slurring speech,
heaviness,
vision, blurred vision,
sudden unsteadiness, like sudden imbalance, and sudden paralysis of one side of the body. It may be just the face and the arm. It may be the entire one side,
left
including
side or right
right or left. And there may sometimes be sudden double vision, or sudden severe headache. Sometimes may be the pointers to a bleeding type of stroke. That is also there. But the key word that we have to remember is sudden onset of symptoms. That marks a stroke. It's not like which is going on for
a few days.
Usually, it is to be very sudden. So all sudden onset symptoms should be identified, and
then what does a patient do, or what does maybe a bystander, a family member, an onlooker? Now, suppose we recognize that somebody is having a stroke. What is the immediate plan of action?
So as soon as somebody recognizes it as a stroke, the first thing one must do is go to a nearby hospital which is stroke ready. That's the first most important step.
Yes.
Of course, if it's a huge stroke and the deficit which has occurred suddenly is very huge, like the paralysis is complete paralysis in which the person is just unable to stand and falls down. So we have to support the person, prevent the injury from happening. Suppose he is gagging because of unconsciousness, which may happen sometimes in huge strokes. Then of course you have to put the person on the side, just not let him choke, prevent injury, call the ambulance, bring him to the hospital. But in minor strokes also, when patients are fully conscious and they just have a weakness, then also whenever a person is identified to be having stroke-like symptoms, he should present to the emergency of a stroke-ready hospital. Because there are certain deficits which we call transient ischemic attacks, in which what happens that the person got a facial weakness or one-sided weakness which lasted for a few minutes, usually maybe 10 minutes, 5 minutes, 20 minutes, and it recovers.
Usually people ignore them.
And it recovers on its own. They are called transient ischemic attacks or mini strokes. But they are harbingers of bigger strokes, because usually after a mini stroke, a person may have a big stroke within a week. So if there is a warning sign, warning stroke like this, one must definitely go, even if the weakness has recovered completely, because it requires evaluation. And we might sometimes prevent bigger strokes, bigger strokes from happening, because bigger strokes means there's a lot of disability associated with it. Life changes after a stroke. So the first step that anybody should take is to present to the emergency department of a stroke-ready hospital.
Now, I know you said that most important is to get to a hospital immediately. Now, when you say immediately, how quick? What should the response time be?
See, as soon as possible, and that is the thing that in the society everyone should become aware of now, because gone are the days when stroke was a thing that stroke has taken place and now we have to just give physiotherapy. So as soon as you recognize that there are stroke-like symptoms, the person should come to the emergency room, because nowadays we have treatments for acute stroke which can be given only within the golden period. That is a time window after stroke, which is considered to be 3 hours to 4.5 hours of onset of a stroke. So the time window is quite small, because if the person comes to us with a stroke during that time window. And through the evaluation, clinical as well as scans, we are able to identify him as a person who can be offered a treatment, what we call clot busting medication, that is intravenous thrombolysis. So that can be offered to the patients if they present to us within 4.5 hours of having that stroke.
Okay.
So every minute you lose, you are losing time. And why? Why this window? Because we are able to save a lot of brain tissue from getting damaged if the treatment is administered within this time window. In stroke treatment, we say that time is brain, because when blood flow to the brain stops, that time, as Dr. Charu just mentioned, that the brain cells do not receive enough oxygen, enough glucose, and they start dying. So that area of the brain tissue, there is a center which we call the core. So some amount of the tissue gets permanently damaged, but there is a bigger area around which is getting less supply, but it's still living.
Okay, which can be
helped, salvaged.
Yes.
We call it the ischemic penumbra.
Okay.
So if you are able to open the supply of blood to that part of the brain timely, then you are able to save a lot of brain tissue, because every minute of stoppage of blood supply to a certain part of the brain leads to loss of 2 million cells in the brain.
Wow.
Every minute.
And that in turn affects bodily functions.
Yeah, the more cells you lose, the more bodily functions you lose. So if a person comes within that golden window period, then we can administer that treatment timely and save more and more brain tissue. So that's the idea. We want to save more and more brain tissue after the occurrence of a stroke, so that the later on disability can be reduced.
So you said that you have clot busting.
Yes.
Now, are there any other recent advancements in stroke management?
Yes. So one is this simplest intravenous thrombolysis, the clot buster medication that I told you about. So what it does is it clears the clot.
Okay.
Okay. Wherever the clot is blocking the blood vessel, it can clear it. And sometimes we see very magical results also, that a person who came with a weakness because of the injection, that clot got dissolved and the blood supply got restored and he started moving his hands. But it doesn't happen all the time.
Okay.
Okay. But even then, whatever studies over a period of time have been conducted, they tell us that the final recovery that person will be having in terms of the functioning will be much better at the end of 3 months if he has received this IV thrombolysis.
Okay.
Okay. Now this is intravenous thrombolysis, in which we just give an intravenous injection like other injections.
Correct.
Of course, we have to observe them for the complications. Sometimes hemorrhage can take place because of the injection. But apart from this intravenous thrombolysis, if the blood supply is not restored, then there is something called intra-arterial thrombolysis.
Okay.
And then there is something called mechanical thrombectomy. So these are the recent things, advances, and which is the arena of the interventional radiologist or the neurologist. So Dr.
Charudutt will tell us more about that, Doctor. Could you elaborate on more of these?
What is important here is the time window in which the patient reaches. So when the patient reaches somewhere within 4.5 to 6 hours, we have all these therapies that we can offer. And a stroke evolves again over 6 to 18 hours.
Okay.
So evolving means continuing to do damage till the final damage is achieved by around 18 hours or 20 hours. So it is much before that that we should initiate therapies which can be aimed at clearing the blocking agent, that is the clot. So this clot can be broken down by injecting medicines which are called thrombolytics. Those are again administered within 4.5 hours of noticing the first symptom of the stroke.
Okay.
So it is very important that the patient reaches within this time frame and you can give the clot busting medicine. If the clot burden is more, there is a chance that the clot busting medicines may not be able to dissolve this clot. And in that scenario, we need to actually go inside into the blood vessel, which is a size of around 4 to 2.5 millimeters, and pull out the clot manually. So there are a lot of therapies which are now established, and the therapy is established when a lot of research came out in somewhere around 2015, when a lot of papers were published wherein the clot was actually pulled out from the arteries, and this was the era where mechanical thrombectomy for stroke started getting established. So from 2015, a lot of work and research has been done in this area where we actually go inside and pull out the clot. Now, this doesn't mean that the clot busting medicine which you have injected is ineffective, and that is why we are doing this.
Okay.
But there are smaller clots which actually go more distally, and they need to be broken down by the medicine. And we can pull out the larger clots which are there, bigger ones which are there in arteries which are the size of around 2 millimeters or larger than that.
Okay.
And we have devices now to go inside and pull out clot from even smaller arteries. So what exactly are these devices is that you can actually suck the clot out by using specific pumps which are attached to tubes, or we call them catheters, which are taken right to the point of the clot, and you suck them up like a vacuum suction device. Okay. So this clot can be pulled out with suction thrombectomy. Then you have something called as stent retriever thrombectomy. It is like putting in a fishing net and doing fishing. You catch the fish by throwing a net. Similarly, in this stent retriever thrombectomy, you actually place a stent which is attached through a wire, and the wire reaches right up to your groins, and you can actually manipulate the stent with your wire. So this stent is deployed at the point where the clot is. The stent engages the clot, and you pull out the whole assembly with the clot out. The whole stent is pulled out, and it catches the clot from the point where it is blocked, and you can pull it out of the groin from where you have entered to reach the point of block in the brain. So these two therapies, that is suction thrombectomy of the clot and stent retriever thrombectomy of the clot, are newer advances in stroke management, where you can immediately clear the clot. Even bursting or clot busting medicines may take some time, but a stent retriever thrombectomy or suction thrombectomy can actually clear the clot within 25 minutes to 45 minutes from the time you start doing the procedure. Would
patient prognosis be better? Be also better? As compared
so if your cell death rate is somewhere around 1.9 million cells per minute, so every minute that you have saved, you are saving that many cells by actually doing this therapy.
Okay, so what you're saying is that it's faster.
It is faster, yes.
I think that's remarkable medical progress. Doctor, however, is there anything that we can do to prevent strokes from happening? Are there any risk factors that our viewers need to be aware of?
Yeah, of course. The risk factors for stroke and heart disease have a lot in common, like high blood pressure, hypertension. That is one of the risk factors. Uncontrolled diabetes, that is a risk factor. Cardiac diseases, if somebody is suffering from any cardiac disease like heart attack, and there are some valvular diseases, that of the heart, they also put a patient at risk for strokes. Cholesterol, dyslipidemia. Then there are many other factors, but more important one is smoking. Smoking is a very, very important risk factor for stroke, much more than alcohol.
Okay.
Alcohol is still a milder risk factor, but smoking is a much bigger risk factor for having strokes and cardiac diseases. A sedentary lifestyle usually promotes all these things. And then there are a lot of other minor risk factors. In younger strokes, some people have some autoimmune problems, connective tissue disorders, such things. Certain blood related problems, vitamin deficiencies, homocysteine. There are many other smaller minor factors, but these in general are the bigger ones.
Actually, stroke prevention, we in medical terms, we put it into two categories. One is primary stroke prevention and secondary stroke prevention. So primary stroke prevention is what Dr. Parul has already spoken
first
about.
time.
Yes. So somebody who has not got a stroke, and we don't want him to get stroke, but is having all these risk factors like diabetes or other risk factors like smoking, BP or any cardiac elements. So then they need to be put on medications or do lifestyle modifications which can reduce the risk of stroke.
Try and prevent. Okay.
Yes.
So you cannot completely prevent, but at least reduce the risk burden by addressing all these risk factors which can cause stroke. So now we also have this other prevention which is called secondary prevention. So sometimes you may get a stroke and you have recovered from it completely, or you have a minimal deficit. You don't want him to get another stroke, which could again be devastating, and he may have a major paralysis following the second stroke. So we want him to, we want to prevent this next stroke happening, and that is when we call it secondary prevention. So when you have a stroke, you have risk factors. You may have blocks in your arteries, or you may have something coming from the heart. So you identify all these problems during your assessment of the first stroke, and once you have assessed and you found out any additional risk factors, you try to eliminate them or reduce the burden of these risk factors. You may have blood vessel blocks in your arteries which go to the brain. These blocks can be removed, and we call them procedures like carotid stenting or carotid angioplasty, or any other blood vessels which are there in the pathway between the heart and the brain, which may have blocks, and you may try to open them and to prevent a secondary stroke from happening.
So, Dr. Charu was telling about secondary prevention.
Yes.
So once a ischemic stroke has taken place, then we have to always put the person on blood thinners.
Okay.
So that comes in the secondary prevention. Secondly, one most important point that he touched upon is sometimes we find these arteries which go from the heart to the brain. They are blocks. And there's a certain percentage when we call it critical stenosis.
Okay.
And a person who has already had a stroke and he falls into that category of stenosis, which can be opened up with angioplasty, like you do in the heart. That also prevents a further stroke or a bigger stroke from happening.
So basically, I think the key takeaways today are to recognize the symptoms of a stroke, what to do if you recognize, that time is key, so that we know how do we, as caregivers or as family members, what is to be done if we recognize that someone's having a stroke. And third is risk factors, to recognize risk factors.
Yes.
Thank you so much, Dr. Dubey and Dr. Sambhaji. It's been such an enlightening discussion. I hope it has helped our viewers. Thank you for sharing your valuable insights today.
Thank you. Pleasure to be here.
As we conclude our insightful discussion today, remember, as Doctor said, knowledge and swift action are both paramount in the battle against stroke. Stay vigilant, know the signs, and together let's work towards a healthier future. That's all we have for today's episode of Health Mantra. This is Heather saying bye for today. Keep watching Prudent Media.